All right, one more chance for those of you just signing on to check your audio. Make sure you can hear okay and your level set well. Also, you should be able to see a PowerPoint slide in front of you as well. Great. Well, we're going to go ahead and get going. I know our timeline is a little tight today. We've got about 45 minutes scheduled for this. Thank you so much for joining us today. I do know we have some folks still signing into the room, but just want to welcome you and thank you for popping on today to discuss insulin program that kicks off here on July 1st as a result of the Alex Smith Insulin Affordability Act, championed by many legislators, including one on the Zoom, Representative Howard. So great to have you on. Maybe we'll just take a quick pause and have you do an introduction if you don't mind, but I just want to say thank you to everybody for their support of the Act. I know pharmacies and manufacturers and distributors, et cetera, are anxious to get the program going here on July 1. If you think about it, it's a pretty fast turnaround, April 15th to July 1. So the purpose of today's webinar is really just to give us an opportunity to hear from Dr. Cody Wiberg at the Minnesota Board of Pharmacy. The board's been essential in putting together the framework for this program that begins in just a few days. I know there are others on the line too that have been really mission critical relative to implementation. I think there may be somebody from MNsure on and maybe some other agencies as well. So welcome to you. We will do a presentation here by Dr. Wiberg, and then we'll open it up for questions and answers. At that point, too, feel free if you have any thoughts to join in or to submit your questions via the chat feature. We are recording this presentation in the event that's useful for those of us that weren't able to join us today. And I just want to thank not only Cody from the Board of Pharmacy, but anyone from MNsure and manufacturers, wholesalers, distributors, all the pharmacies and pharmacists on the line today. They'll be on the front line of making sure this program goes well for consumers. But I also want to recognize our friends at the Minnesota Grocers Association. I think Jamie is on, Joel from the National Association of Chain Drugstores, and a couple of his colleagues that are on today. And certainly last, but certainly not least, Sarah, Jeff, and Buck, and others from MPHA that have been just quintessential in sort of working through some of the details and providing context for legislators like Representative Howard as they made decisions on this bill. So Sarah, thank you so much for that. Maybe I'll just take a quick pause. Jamie or Joel or Sarah, does anybody else want to do a quick welcome?
This is Sarah with the Minnesota Pharmacists Association. I just want to thank you all for taking the time to be on this call. I think this is a very intricate bill with pharmacy, and I appreciate all the work that has been done with the legislature. So just wanted to say hello. Thank you.
Great, thanks, Sarah.
And this is Mike Howard. Thank you all so much for, it really was a team effort over more than a year to pass this bill, and it's very exciting that we're, on the cusp of actually making this reality. And you sure are right about the fast turnaround. We didn't give you a whole lot of time at the legislature to get this thing up and running. And so I'm just so grateful to all the folks that you mentioned and everyone on this call. And, I really believe that this is something that's going to save people's lives. And like you said, you're all going to be on the front lines doing this. So I'm really looking forward to hearing about this as we take the next step to make it a reality.
Thanks, Representative Howard, and thank you so much for all your leadership. And I will just say, if nobody's told you, it's deeply appreciated. We want to make sure on the pharmacy side that we get this right. We know, like any new program, there's going to be some bumps, but we're really committed to trying to make sure that when somebody walks in a pharmacy and either they have an emergency need or just an affordability issue working through the program, we want to make sure it goes right. We know there's going to be some issues, but we want to make sure there's great lines of communication open on those as well. So thank you, sir, and thanks for joining us today. Joel or Jamie?
Yep, Bruce, I just want to mirror everyone's comments. Certainly thank you to everyone for taking the time to be here, and Cody to being able to present and walk us through the best practices and how to get there. Bruce for coordinating all of this. I think it's really great, and obviously all of the work that everyone has put into getting us to this point. So thank you, and I look forward to the presentation today.
Thanks, Jamie. Joel?
Joel, I think you're on mute. Joel, try again. I think we might be able to hear you now.
I
right,
believe
Anurag.
Joel posted in the comments and said proceed and that he's grateful in the chat.
Great, thanks, Savannah. Sorry about that little technical blip there. So with that, Dr. Wiberg, let's turn it over to you.
Actually, I would suggest one more thing. I see Nicole is here, and perhaps she would like to make some comments.
Thank you, Cody. Yes, I am listening in today. I just want to thank you all for all the hard work that you have put into this, and so excited to see that this is going to be a go come next week. And thank you. I just want to say thank you.
And Nicole, I did not see you there. Dr. Wiberg, thanks for mentioning that. It's so great to have you on today. Thank you.
Okay, with that, I will get going, and just going to go right to the next slide. So just as a way of introduction, in 2020, as I think we all know if you're on this call, the legislature did pass the Alex Smith Insulin Affordability Act. Governor Walz signed that into law on April 15th, 2020. We've already mentioned that does create kind of tight timelines, but I've been doing a lot of work with the staff at MNsure. They have been doing a great job. I'd like to think that I'm doing an okay job in this too. One thing that I can let you know is that one of the things that I have to do is I'm the contact with the insulin manufacturers. And I can tell you that I've talked to the government affairs reps for all of the big three insulin manufacturers. They have all indicated to me that they intend to comply, which tells me that they do not intend to sue, which of course was kind of a concern, but they all really tell me that they're going to make their best faith effort to get up and running by July 1st. Now, what they have told me is that they will certainly meet the minimal requirements, but they envision sort of tweaking things as they go along. Some of it just cosmetic things, like they plan on they might have a bare bones web page for the Minnesota program that they will make look better and more functional as things go on. Some of the manufacturers might, for the urgent need program, might at first decide to replenish stock for pharmacies because they won't have had enough time to contract with a vendor that can do claims adjudication. But all of them seem to eventually want to move to claims adjudication for pharmacy rather than replenishing stock. I do expect more communication from the manufacturers today and tomorrow. I gave them until, I think it was actually tomorrow, to get me a description of exactly what they're going to do for the Minnesota program so that I can get that into the documents that we have on our website. So the Act does create an insulin safety net program, and that is what MNsure and the board are calling it, the Minnesota Insulin Safety Net Program. It's going to aid individuals who can't afford insulin. And as I mentioned, the board and MNsure were the primary state agencies directed to implement the program by July 1st, 2020. Minnesota Department of Health has a role as well, but I think that comes in a little bit later in terms of doing satisfaction surveys, that sort of thing. And again, from all the work that I've done with MNsure, talking with the manufacturers, I think we're going to be ready by July 1st for this to go operational. So we have created a separate web page for the program on our website. The URL is there. Currently, if you go on that, you're only going to see a guidance document. At its May 20th, 2020 meeting, the board adopted a guidance document, and health licensing boards by law can issue guidances to sort of, if the language in the law allows for perhaps different ways of doing things, or if there's even a hint of any sort of ambiguity, agencies can sort of fill in the blanks with a guidance document. And that's what we've done with that document. That's up right now. And then I have written up FAQ documents for pharmacies and pharmacists. I'm just about done with the FAQ document for manufacturers. I've also finished a patient information sheet that's required by the law. And we're going to have a link to the website that MNsure has put together, or is putting together. The URL for that is there too. They've actually, I think, trademarked the name, if you will, mininsulin.org. And then our website is going to have a list of trained navigators as well. Again, we're working with MNsure to make sure that we roll this out sort of simultaneously. So I haven't added some of these documents yet. I'm working with MNsure to see exactly when we're both kind of go live, so that, you know, we don't want the board's website to go up too quickly and have links to MNsure's website when it's not up, or vice versa. But I think sometime in the next 2-3 business days, maybe by Monday, I think the websites will be up. One thing that I'm going to do for pharmacies is I'll be having my office manager either this afternoon or tomorrow send out a mass email to all pharmacies, pharmacists, pharmacy technicians, pharmacy interns in the state of Minnesota, to which I'm going to attach that pharmacy FAQ document so people can start looking at it right now. MNsure, as I mentioned, has created the separate website, and they're going to have an application for the urgent need program, a tool to search for trained navigators, and a list of the navigators, and additional information about the program. I've seen a mock-up of it. I think it looks great. And so again, I think both of our agencies are really close to having everything out there so that the public and pharmacies and manufacturers and everyone involved can look at those two websites and really understand the program. There are two parts to the program, the urgent need part and the continuing need part. So for urgent need, this is going to allow individuals who are in urgent need of insulin, which is actually defined as essentially having less than a 7-day supply of insulin on hand. It's going to allow them to get a one-time 30-day supply of insulin from their pharmacy for a $35 copay. Normally, an emergency supply can only be obtained once in a 12-month period. There is an option for some individuals in certain circumstances to receive a second 30-day supply. For the sake of time, I'm not going to go over that, but it's all spelled out in the documents that'll be on our website. Insulin manufacturers have a choice, and I sort of alluded to that before. They can reimburse pharmacies for the cost of the insulin, or they can send the pharmacy a replacement supply. The continuing need program requires manufacturers to provide insulin to eligible individuals for up to 1 year with the option for the person to renew annually as long as they remain eligible. They will need to provide up to a 90-day supply of insulin for a copay of no more than $50. And individuals with insurance may also be able to obtain insulin through a manufacturer's existing copay program, which waives all or part of the copay. So the Minnesota program doesn't completely replace the sorts of programs that manufacturers have in place. There is still potentially a role for some of their programs as well, but we've made it really clear to the manufacturers that they always have to have in place a program that at least meets the requirements set out in law. If they offer something that's even better, and they get the patient's permission to use that better program, they can do that, but they always have to have this program. And if they ever cancel any of their programs that might be more generous, they have to tell the patient they're canceling it, and they have to allow them to enroll in the program that's set up. We didn't want to prevent the manufacturers from being even more generous than the law allows, but we also don't want them to cancel out the programs and leave people in a lurch. So now I'm going to go through some of the FAQs for pharmacists and pharmacies. These are actually taken directly from the document that's going to be on our website. It's not all of the FAQs, again, for the sake of time, but it's probably the ones that are most important to cover today. And I'm not going to read these verbatim, word for word, but and by the way, this PowerPoint, Bruce can distribute it. I'm actually going to put this up on our website too. So this will be available as a resource as well. But the first question is just what types of insulin are covered? And essentially, just about any insulin that's going to be dispensed in a community pharmacy will be covered. There are a few insulins that are only used within a hospital. I think Baxter makes some insulin in piggyback bags that are only used within hospitals. There's a provision put in there that, you know, it says products made by smaller insulin manufacturers. I'm not even aware actually of smaller insulin manufacturers. I'm only aware of the big three, but at some point maybe the intent was if there's ever any biosimilars from a small company or something, perhaps they wouldn't be covered. And then, and I emphasize relatively inexpensive insulins that pharmacies can usually purchase for less than $8 per milliliter would also not be covered here. But I think most of the, and maybe that's the older insulins, like, you know, the Walmart Relion or something might fall in that category. But most of the insulins, the more modern insulins, if you will, that people get prescribed, if not all of them, they're going to be covered under this program. Might be a little bit hard to read, but the gist of this is, are pharmacies required to participate in this program? The answer is yes. If you are a pharmacy located in Minnesota, and if you are licensed in the community outpatient category, you do have to participate in the program. There's only a few reasons where you could refuse to fill a clinically and legally valid prescription. And that would be if you don't have the insulin in stock, obviously you can't dispense it. If the application that the patient gives you for the urgent need program is not correctly filled out and signed, or if the patient would refuse to pay the copay. But as we expect for filling any prescriptions, if a pharmacy doesn't have the insulin in stock, you should be working with the patient to determine if they have enough insulin so that they can wait until you can get it into stock. If not, you should assist them to find a pharmacy close by that might have that insulin in stock. And in addition, if the application is not filled out correctly, and I think pharmacists, there's no requirement in the law that the pharmacist help patients fill out the application, but again, I think that's a professional standard to help people do things like that. So you can work with the patient to make sure that application is correctly filled out. And then again, a little bit hard to see, what does a patient need to do? Let me just decline this phone call here. What does a patient need to do to receive insulin? Well, first they do need to fill out an application. That's going to be available on mininsulin.org, or the law says that pharmacies need to make it available. You can get the application on that website and print it out. And it may also be available from clinics, emergency departments, and urgent care centers. What this board is going to do is we are going to give information to the boards that license prescribers about this program. They are required to notify their licensees about the program. And so it's possible that if a patient goes into see their physician or into an urgent care center or emergency room, they will have access to the applications and be able to print it out and give it to the patient as well. The patient needs to bring the completed, signed, dated application to the pharmacy. Also, this program requires prescriptions, so the patient might bring in a new prescription, or they might already have a prescription for insulin on file with that pharmacy, and so they'll need that. And the final thing they need to do is provide identification that verifies they live in Minnesota. That could be a valid driver's license, Minnesota ID card, a tribal ID card from a Minnesota tribe. If the person is under 18 and they don't have any of those IDs, then the parent or guardian would have to show proof of residency. And one thing, just to let you know, I'm not sure it's showing up on this slide, but just as we have done for other requirements for ID, like the requirement for that people have to show ID when they pick up controlled substance prescriptions, the board went on record as part of its guidance document as saying that as long as there is a peacetime emergency declared by the governor for COVID-19, pharmacies can rely on expired IDs, because people are still having a difficult time getting in to have their licenses renewed and their IDs renewed. Oops, I went a little bit too far there. So if they do those things and everything's in order, then what the pharmacy is supposed to do is dispense a 30-day supply of insulin. The only way a lesser amount can be dispensed is if you don't have a prescription for a 30-day supply. But again, we would ask pharmacists to work with the patient and their prescriber to make sure that there is an a prescription that allows the pharmacy to dispense the full 30-day supply. The pharmacy is allowed to collect a $35 copay for the 30-day supply. The pharmacy has to notify the prescriber within 72 hours that the patient received that supply. That can be done by telephone, letter, or facsimile. The reason for this happening is to make sure that the prescriber knows that this is happening, because as I mentioned earlier, there are other insulin manufacturer programs that manufacture insulin programs that still exist, and those programs send to the prescriber. So this is a way for the prescriber to know that the person's already received a supply of insulin. You have to retain a copy of the application that is brought in. The law doesn't, this is where we did some guidance. The law doesn't specify how long that has to be retained, but all other pharmacy records, like filled prescriptions, have to be retained for 2 years. And so the board thought it was reasonable to require pharmacies to retain these applications for 2 years. A patient can receive, for the most part, receive a 30-day urgent need supply of insulin only once every 12 months, unless one of these things applies. one of the reasons that navigators are involved, I think, is that they can potentially assist individuals in potentially getting insurance, or they can direct them to where they need to go to apply for medical assistance or Minnesota Care. Because I think what the legislature envisioned here is that there would be this urgent supply given, but that doesn't solve the longer term problem. And so there needed to be various options. And some of those options would be, if the person's eligible, getting them enrolled in medical assistance or Minnesota Care. So if the patient's applied for one of those two programs and they haven't received an eligibility determination, or they've been determined to be eligible, but their coverage is not effective yet, they can get a second 30-day supply. Another option for continuing insulin supplies would be through the continuing need portion of this program, which we'll talk about in a little bit. And if a manufacturer has determined that the patient is not eligible for the continuing need safety net program, and the patient has asked the Board of Pharmacy to do an eligibility review, and we haven't made a decision yet, they can also get a supply. Now, pharmacists among you might be thinking, how are we going to know that? I'm going to cover that here in just a second. Right here, how will you know? Well, for the manufacturers, and again, I think ultimately they're all going to do this, but for the manufacturers that right from the start use a claims adjudicator, that's going to work like a PBM works, right? And so if you have submitted, or some other pharmacy, say, has submitted a claim through that claims adjudicator and the claim has been paid, if the patient were to go to a different pharmacy at some point in the future, within that 12-month period of time, and you try to submit a claim, presumably you're going to get a reject because the patient's already received a 12-month supply. And then you'll have to, like you do with any reject you get from any time you process a claim, you'll have to probably dig into that and figure out why the reject occurred. Now, the next paragraph there is a little bit more, again, about where we had to issue some guidance. So if a manufacturer decides not to initially, or can't initially, use a claims adjudicator and sends a replacement supply of insulin, there's no way that a pharmacy is going to know that a patient's been to another pharmacy to get insulin, because there's no claims adjudication to check. And so in that case, the board's expectation is the pharmacy will presume that this person is eligible for that emergency supply of insulin and will dispense it, and the manufacturer will be required to pay for that second 30-day supply. Even if at the end of the day, it turns out the patient wasn't supposed to get that second supply. We're going to err, I think, on the side of the patient getting this medication that they need to sustain their life. And again, with replacement, there's simply no way for a pharmacy to know if the patient received another supply. Next question we anticipate getting, does the pharmacy have to verify any of the information on the application? The answer is no, you do not. By signing the application, the patient is attesting to the accuracy of the information. So the only thing that you have to check at the pharmacy is the identification that verifies Minnesota residency. Pharmacy technicians can check the ID, and this is where I've got that note that as long as there's a COVID-19 peacetime emergency, you can accept a expired ID card. How will the pharmacy be reimbursed for the cost of the insulin dispensed? Again, initially, I think at least one of the manufacturers, maybe two, are going to use claims adjudicators, and the law actually specifies that if they are reimbursing pharmacies rather than replacing supply, they have to use NCPDP billing standards, which means it has to be an electronic transaction. It has to use those standards, and the manufacturer can't require pharmacies to submit paper claims. Now, the law does say that pharmacies are supposed to submit a claim for their actual acquisition costs. So that is what we expect pharmacies to do. And this is another bit of guidance. If the amount you are submitting as your cost exceeds NADAC, which is the cost database, if you will, that Medicaid uses. If you're saying that it cost you more than what the NADAC cost is, you should have documentation in place that your cost really was above NADAC. You should not submit a dispensing fee as you normally would for some other PBM claim, but this reminds you that you are collecting a $35 copay from the patient, and you're keeping that entire copay. That copay is not split with the claims adjudicator or going back to the manufacturer or going to fund the program in some sort of a way. So pharmacy does get reimbursed in addition to the cost of the drug for the work that's involved. And another bit of guidance is based on current practices for reimbursement of claims. We think the manufacturers should be reimbursing pharmacies within 14 days of the claim submission. Can the manufacturer send a replacement supply? Yes, I've already alluded to that. They can do that. This is another bit of the guidance. It doesn't specify the law doesn't specify how quickly the manufacturer must send a replacement supply, but we're going to use that same 14-day standard. Now, I believe in talking to the manufacturers that they will have some sort of a form that you would need to submit to them, and they're allowed to do that. And that's the sort of information, the additional information I'm hoping to get from them today and tomorrow, so I can incorporate over the weekend that information into these documents so pharmacies will have it for each of the manufacturers. So moving on to the continuing need portion of the program. And by the way, I haven't gone over eligibility here. Pharmacists really aren't required to determine eligibility, but all of the eligibility requirements are in the pharmacist FAQ document for you to look at. And this is the first question here is just that. Are you required to determine if a patient is eligible to receive insulin for continuing need portion? No, you are not, because for the continuing need portion, they need to apply through the insulin manufacturer, and the insulin manufacturer will have to have either an online way of people to apply and or a paper way that people can apply. Again, that's some more of the additional information the manufacturers are supposed to get me in this next couple of days. Now, once the manufacturer determines a patient's eligible for continuing need, they have to give the patient an eligibility statement. That could be in the form of a letter, or it could be in the form of a card. And so the law envisions that for the continuing need program, manufacturers will replace the insulin. However, the law doesn't prohibit the manufacturers from also using claims adjudication for the continuing need program, and claims adjudication would be better for the manufacturers and for the pharmacies. It reduces a lot of the administrative work. So the board is going to allow for the continuing need program, going to allow the manufacturers to use claims adjudicators. The bottom line is the pharmacy has to get reimbursed for their actual acquisition cost. And whether or not the pharmacy is reimbursed for the continuing need program or the insulin is replaced should have no impact at all on the patients. That should be all in the background for them. How will a patient obtain a continuing need supply? So again, this is the way the law envisions it. Patients need to provide the pharmacy with a statement of eligibility or the card. If the manufacturer is going to replenish the insulin and not use a claims adjudicator for this part of the program, the patient would come in with an eligibility statement saying that, yes, they are eligible. They're also, again, going to have to provide the pharmacy with a prescription. In this case, the pharmacy would be dispensing up to a 90-day supply of the insulin if the prescription allows for that much. What I said before remains true. If you don't have a prescription for a 90-day supply, we think you should be working with a prescriber to try to get a prescription that will allow you to dispense a 90-day supply. If the manufacturer is going to replenish, they'll be providing a form, and you would have to fill out that form and you'd have to provide them with your pharmacy's name and shipping address, an office telephone number, a fax number, an email address, the person to contact, and any specific days or times when you could not accept delivery of the insulin. So again, this is based on how the law is written, but at least some of the manufacturers I would like to actually just reimburse pharmacies. And if that's the case, then you could fill the prescription right on the day that the patient comes in and get reimbursed. Otherwise, what we have in the patient information sheet, we have told patients that it would be best if they work with their pharmacies at least 2 weeks in advance of when they need the insulin, because if the manufacturer is going to replenish, the pharmacy is really not going to be dispensing the drug at that point until the insulin comes in for that specific patient, and that could take up to 2 weeks. And this goes into the rest of that. So under the way the law is written, patient would come in, the pharmacy would provide the information necessary to the manufacturer to ship the insulin, and then the manufacturer would ship the insulin so that the patient can pick it up. We've expecting the manufacturer to do that within 14 days. But the pharmacy in that case would not be giving the insulin to the patient on that day, which again is why I think if they can work at claims adjudication into this, that would be good. That would be better for everyone. It would be less work for the pharmacy, less work for the manufacturer, and the patient wouldn't have to go to the pharmacy twice. The insulin in either one of these programs actually needs to be labeled just like you would label any other drug that you dispense. In this case, the pharmacy is allowed to collect a copayment of up to $50 for each 90-day supply. Again, the pharmacy keeps that $50 copay. It's not split with anyone. And if the manufacturers use claims adjudication for this part of the program, it's the same thing. Pharmacies should only be submitting their actual acquisition cost and no dispensing fee. You are, for the Minnesota continuing safety net program, you're not allowed to bill any insurance that the patient might have. But the law does allow the manufacturers, once they get that continuing need application, to say, oh, wait a minute, we see that you have insurance where you pay a copay. Our existing copay program is better, so we're going to enroll you in that. So if you see a patient coming in with the sort of information that manufacturers provide for an existing copay program, then you would bill the primary insurance first and bill the manufacturer's claims adjudicator as the secondary payer. That process needs to be completed for each 90-day supply of insulin the patient receives. And then at the bottom, that's just what I've already gone over. We are going to allow them to use claims adjudication for the continuing need portion of the program. Does a pharmacist have to fill prescriptions for the program if the pharmacist has valid clinical concerns? This is another part of the guidance document. So the law just says that the person has to bring in a valid prescription, but doesn't define what that means. And prescriptions can either be legally valid, which means they meet all the legal requirements of the prescription, they have every piece of information on the prescription that legally needs to be on there, doesn't mean that they're clinically valid, which means one of the primary duties of a dispensing pharmacist is to review that prescription and make sure the prescriber has not made an error. So as with any other prescription, if you are doing your patient profile review and your drug utilization review, and you think that if you, in your professional judgment, you think the patient could be harmed, then you're not required to fill it. But just as we have always expected in situations like that, in fact, our rules even say this: if you do a DUR and you identify a problem like that, you're required by rule to contact the prescriber and resolve the clinical concerns. And ultimately, the hope then is that you're going to dispense the insulin. Are there any other obligations pharmacies and pharmacists have in relation to this program? Yes, if asked, pharmacists must provide patients with a list of trained navigators. I just confirmed with MNsure today that they have a really nice feature that they're going to have on their website where people can search for navigators, but they will have a list available as well, and that will be on, I believe, their website and our website. And so if asked, you do have to provide that. You can ask the patient if they would rather have the link to the websites and just do that themselves. They can do that if they agree. But if they ask for it and don't want to look on the websites, you do have to give a list of trained navigators. And it's the same thing with the application as well. So my last slide, and the information sheet. I mentioned that we have FAQ documents for pharmacies, pharmacists, for manufacturers. We have the guidance document. The one document that's required by law is a Minnesota Insulin Safety Net Program information for patients sheet. That will be on our website. And if a patient asks for that and don't want to be referred to our website, you would have to provide that to them as well. And then finally, and this is just an extension of what pharmacies have are supposed to be doing since, I think, probably July 1st of last year. You may be aware that the board, in addition to this new Insulin Safety Net webpage, we established a more general webpage last year to give people ideas about how they could save on any prescription drug. That webpage is going to have a link to the insulin webpage, and pharmacies and pharmacists are going to be continue to be required to let patients know about that webpage that we have. Now, given COVID-19 and the civil unrest and trying to get the insulin program up and running and a number of other things, one thing that we haven't had a chance to do, but we will do, is a law last year that created that page that gives ideas for people on how to save drugs, also directs us to develop posters and brochures that people could hand out at pharmacies or put on the wall of doctors' offices. We will be doing that over the next month to a month and a half as well. And that's another way to meet the requirement of notifying patients. With that, I don't know, Bruce, if you want to have time for questions or...
We do. So we're against our 45 minutes right now. So if
Yep.
those of you that have to pop off, feel free to do so. There were some questions that came in via the chat, and just a big thank you to Jeff Lindu. He's actually been fielding those as we go along here, but there is one here for you, Cody, that I think is good. So everybody, I'll draw your attention to the chat bucket so you can see some of those questions and answers. But question for you, Cody, would the board consider it unprofessional conduct if the 90-day supply doesn't come from the manufacturer in the time needed by the patient, and the pharmacy dispensed the insulin from their inventory and then used the patient's supply from the manufacturer to replenish their inventory? That's a very practical question.
Yeah, and one I probably have to think about. Probably not is just my first thing, but I got to think about that a little bit. I would think not. one reason I'm hesitating is there's of course a risk for the pharmacy at that point because it may never come. but if it's going to come directly from the manufacturer, and it should come from them delivered in a way to maintain the integrity of the drug product. And so if the pharmacy wants to take the risk that maybe it's not going to come, and dispense the supply to the insulin when it actually does then come in, as long as it's the same insulin and all that, I don't think so. But I do want to think about that a little bit more. But I can't see why that would cause any harm to the patient or somehow be fraud against the manufacturer or anything like that. Just kind of thinking about it quickly here.
Great. No, appreciate that. And I know part of this whole webinar is to sort of flag some of those issues that we
Yeah.
can think of a little more. So thank you for that.
Yep.
Here's a quick one. If this is back to the supply question, if one vial or box says it's a 25-day supply, would you then dispense 2 packages or essentially 50 days for that $35 copay?
Well, what the law says is a 30-day supply. So I would say that if the pharmacy, that just isn't possible with the sort of insulin involved, I think the pharmacy could dispense over a 30-day supply. I think that's how it is. And by the way, please send me these.
I will. Yeah, we'll capture them.
Incorporate them into the FAQ document.
Yeah, there's a few other good ones here too where Jeff had answers, so we won't go through those.
Yeah.
But let's pick up any questions that people want to ask verbally right now. You could unmute yourself if you had a question. As you think about that, Cody, here's one. If the patient doesn't come back in to pick up the insulin for the continuing supply,
Mm-hmm.
what would be the protocol? What would the pharmacy do with that inventory? Would there be sort of a timeline to hold the product, or what do you envision there? Again, another very practical question.
Yeah, and one I'm going to have to think about a little bit. So here's the thing. I think that patients need to have some time to be able to come in and pick up the insulin. Maybe something happened and they could not get in to do it. So I think that the pharmacy should hold it for some period of time, should be trying to contact the patient to see why they're not coming in. I suppose at some point, if they don't come back in, then to be fair to the manufacturer, we probably should end up getting shipped back to them. But again, to potentially, I think, save the pharmacy work too, is you're going to want to give that some time, because you're not going to, if the patient is going to come in after 2 weeks and they don't come in, you probably don't want to send back the next day, because they'll come 3 days later and it messes the whole process up. But we'll probably, this is one of those things too, where we'll probably leave it up a little bit to the professional judgment of the pharmacist, because they know the situation, they know the patient better than we ever could. But at some point, if you just can't get a hold of the patient and it's been 2 weeks or more past the time they were supposed to get it, it'll, I guess, probably have to be sent back to the manufacturer.
On the manufacturer side, can a manufacturer use short-dated product if it has at least 90 days left?
Yeah, there's certainly nothing in the law about that, but it is definitely going to have to have an expiration date that is not just within 90 days. It's going to have to be more than that, because there takes some time to get it to the pharmacy, and it may be a few days, as we just talked about, before the patient comes in and gets it. So I don't think 90 days. I think it would have to have at least 120 days or more of active shelf life, at least.
And Cody, as a way to see if anything else, oh, here's one. If a single patient if single patient use syringes are packaged in multiples of 2 to 5 syringes and the FDA doesn't want the pharmacy to break up the package, so the FDA component, what's the guidance on dispensing that related to
The-
the supply
yeah,
limit?
and this changes, but the latest information I believe I have is the FDA does not want the packages broken up. And that goes against, I think, what some PBMs were telling pharmacies for a while. And so, but if the FDA is saying that these should not be broken up when they're dispensed to patients, then it goes back to what we were talking about before. If one box lasts 20 days, then to get the 30 days, you'd have to dispense 2 boxes, I think.
So Dr. Wiberg, I think I mentioned on the front end that certainly, you know, things are going to pop up. And I think we've got a few things flagged in the chat that we can cycle back with you on.
Mm-hmm.
And for Nicole, we want to honor your amazing advocacy on this, and Representative Howard, your great legislative work. There's certainly going to be some bumps along the road. Cody, what's the best way for us to kind of capture things that we see as the program rolls out, as we try to improve it, make it work better for patients, make it better for pharmacies and manufacturers?
Well,
Do
so
we just work through our local associations on that, or what's the best way?
I mean, as a, yeah, it comes to you, comments, concerns, forward on directly. Pharmacy every single day, voice message to go in a mail box for the pharmacy inspectors. Them, they're full, and buck stop else the office in email box or brought into my office.
Cody, I think will you pause there just for a second, because I think your audio is cutting in and out, so we'll give your internet just a quick second to catch up. So try that again. There we go.
In and out.
Yeah, you're still popping in and out. Yeah, sort of rhythmically, actually. Yeah.
Let me try something else.
Okay.
Can you hear me now?
I think you're still popping in and out, but I'll tell you what, you did it at just the right time. You're now than earlier.
Happening is my running out.
So I think for those of you on the webinar, we'll any of the associations on, I know we're happy to collect any feedback that you have. I know Dr. Wiberg and his staff are very responsive too, so we'll just keep working through issues as they pop up, because they certainly will. But I just I want to end things again just by thanking Nicole for her amazing advocacy. Our hearts break for the story behind your advocacy. But thank you so much for your work on this, and for folks like Representative Howard that have worked so hard to get this done. And again, I think we owe a good debt of gratitude to our friends at MPHA for the great work that they have done on this, Jeff and Sarah and Buck, and to our partners, Jamie and Joel as well. I know, like I said, there'll be more issues that pop up, and we'd love to just keep in contact on those. But again, let's do our part. And I know all of our pharmacies and pharmacists are committing to, when that patient walks in the door, even though the process may not be easy, as you've seen, there's a lot of steps to it for a pharmacy. We want to make sure it works for the patient, ultimately works for the pharmacy and the manufacturer, and all the others involved as well. So keep up that commitment. We appreciate it very much. I think maybe we'll see if Dr. Wiberg will just kind of hang on. I'll stop the recording now, but we'll see if he'll just hang on just to see if there's any other issues that pop up. If you want a copy of the presentation, I think all of you, I should have your email address so we can send that on. We'll capture the chat too, which has got some great questions that we can forward to you, Dr. Wiberg, as well. But with that, I will stop the recording. But again, thank you so much, everybody, for joining us. And Dr. Wiberg, thanks for giving so gracious of your time. I guess actually, before I stop the recording, I will extend one more compliment. I know up at the Capitol, there are people who sort of try to demand respect and people who earn it. And Dr. Wiberg and his crew there at the Board of Pharmacy over the years has been one of those entities that has really earned a lot of respect. As he mentioned, there's just so many of these programs, from drug transparency to opioids, to insulin that come up, and legislators really do look to you, Dr. Wiberg, and your professionalism relative to not only helping figure out what things should look like, but how they roll out as well. So kudos to you on that. So thanks again, everybody, for joining us today. Hope you have a great day.